Hello, everyone. Good morning. Thank you for joining us. I'm Monica Kraft, the Assistant Chair of Medicine at the Icahn School of Medicine at Mount Sinai, and we're here to talk about some exciting developments in innovation in women's health. And I'm so pleased that the Aspen Ideas Health has decided to put a spotlight on women's health, because I know in some ways it's been a very challenging year. But I hope you walk out of this panel with a sense of optimism and excitement about what the advances are in women's health. It's a very exciting time to be in the area. And I'm surrounded by my outstanding Mount Sinai colleagues, and I'd like each of them to give an introduction. So I'd like to start with Dr. Port.
Hi, thank you so much for attending. It's an honor to be here. I'm Dr. Lisa Port. I'm the Chief of Breast Surgery at the Mount Sinai Health System and the Director of the Dubin Breast Center. Thank you.
I'm Dr. Alan Copperman. I am a Mount Sinai faculty member for now nearly 3 decades. I'm Vice Chairman of OBGYN and Reproductive Science, and I run the Division of Reproductive Medicine, and I also run Mount Sinai's IVF Center at RMA of New York.
All right, great. Dr. Malaspina.
Hi, I'm Dr. Dolores Malaspina. I'm a professor of psychiatry, neuroscience, and genetics at the Icahn School of Medicine at Mount Sinai. I am also the system director for the Psychosis Division and the Vice Chair for DEI in the Department of Psychiatry.
Great. All right. So I think I'm going to start with a question to Dr. Port. So Dr. Port, you're in the breast cancer space. There's been huge advancements. So tell us a little bit about how you care for a patient these days compared to how you might have 20 years ago.
Sure. Happy to speak about that. So I think just to set the stage, what a lot of people don't realize is that breast cancer is the most common malignancy to affect women in this country. There's going to be about 300,000 cases diagnosed this year in 2023. So the advances we make affect a lot of people. One of the things that I never get tired of telling people is that, so an interesting fact is that between 2000, the year 2000, and 2010, the death rate from breast cancer dropped 2% each year. Okay? So that means if you were diagnosed with breast cancer after 2010, you were 20% more likely to survive than a decade earlier. And that represents tremendous progress. What's driving that progress? Basically 2 areas. One is early diagnosis. Our technology has gotten better and better. In 1 generation, we've gone from film mammograms, where you take a piece of film and bring it to your doctor, to digital, to then 3D. Okay, 3D mammography is really the current state-of-the-art technology. We were the first ones, actually, at Mount Sinai. I never get tired of bragging about that, at the Dubin Breast Center to get 3D mammography in New York. And it now represents about 50% of the mammograms being done in this country. This technology picks up cancers earlier, when they're infinitely more treatable, curable, and by the way, by doing less. So if your cancer is picked up earlier, you're way less likely to need more aggressive therapies, way less likely to need more extensive surgery. And then the other driver of our progress is even for people whose cancers aren't picked up late, we have so many more treatment options. And there are new options being introduced every year. And so we're just trying to stay ahead of the curve. So if someone doesn't respond to a certain therapy, we have Plan B and Plan C and so forth. And that's where we're at today, which is a great place to be.
Fantastic. So, Dr. Copperman, you've been in the infertility space for many years, and you've been extremely successful, and it's really changed, certainly when I was in that time of life. So maybe you can tell us a little bit about some advances in that arena and how you're really changing women's lives.
Great. Infertility is still egg, sperm, uterus, tubes, and timing. But our understanding of the details has changed dramatically, as is our ability to model the disease itself. So infertility and fertility is a spectrum. There are a lot of people that are subfertile. And what we've learned over time is that precision medicine, concentrating on a family history, concentrating on genetics, concentrating on disease modeling, we're able to personalize health and streamline care. So what used to be 6 months of trying and surgery and low-tech treatments now can very simply be taking out the eggs, fertilizing them, testing an embryo for genetics, for with whole genome sequencing, finding embryos that are destined to lead to a healthy child rather than an unhealthy child or a miscarriage. So what we've taken is big data, personalized it, and now we're achieving success rate more than ever. There are nearly 7 million infertile couples in the United States. Half don't know they're infertile, half don't go to a doctor, half drop out after their first visit. We have a major problem with access to care, and we have to streamline, become more efficient at what we do. But I think with data modeling and access opportunities, we can end some of the disparities in fertility care, and we can lead to healthy outcomes at a rate never seen before.
Oh, that's fantastic. It's really great to hear, really optimistic. Thank you.
It's a time for optimism.
Absolutely. So, Dr. Malaspina, mental health is critical in all of this, especially as women are either being treated for illness or aging. Certainly depression is a challenge, other mental illnesses. So, I wonder if you could comment a little bit on how that intersects with some of the other advances we've been hearing about.
Yeah, my pleasure, Monica. Do you know, I actually entered my psychiatric research career to understand the cause of schizophrenia, the most severe psychiatric illness. My sister, like most other patients with the disease, had no family history. So my interest was, where do these genes come from if this is a genetic and a familial disease? And my great idea at the beginning was the disease genes originate in the older father, that it's actually paternal age that's the greatest source of de novo mutations. And now we have found that, in fact, the rare variants for schizophrenia predominate in many, many cases. Other causes of schizophrenia involve inflammation and exposures. But for the genetic piece, we at Mount Sinai have very, very large repositories of patient information and genetics and phenotypes, and we will be able to sort different pathways of these genes into precision treatments for severe mental illness. But on the other hand, society's greatest suffering is major depression. And for women, they have twice the rate of major depression as do men across the lifespan. My focus is that we must assess patients for depression and provide cutting-edge treatments, particularly understanding that untreated depression is a risk factor for diabetes, for cardiovascular disease, for some cancers, and for women during pregnancy. We need to assess depression and intervene. At Mount Sinai, we have just the best treatment for depression. We have doctors who are screening for depression. And we can treat depression as well or better than other chronic diseases. It's the stigma and the lack of assessment that really limits our ability. For the people with treatment-refractory depression, come to Mount Sinai as well. We have in our pipeline and available the new approaches for treatment-refractory depression.
Beautiful, thank you. I want to pick up on your comment on precision medicine. This is something I think about a lot. I'm in the pulmonary space. I'm a practicing pulmonologist. I take care of patients with severe asthma and COPD, and we've really moved precision medicine forward in terms of understanding that diseases are heterogeneous. It's not a one-size-fits-all. And so understanding these different types of, in my case, asthma or phenotypes, and then how can we really target therapies to the right phenotype? And this really goes beyond pulmonary into all chronic diseases. And so maybe, Dr. Port, maybe you could comment on how precision medicine is being used in breast cancer treatment.
Yes, for sure, it's very applicable. What a lot of people don't understand is that breast cancer, believe it or not, is not just one disease. There are multiple different, what we call subtypes. And the pathway or the journey through a breast cancer treatment for the individual is absolutely not one size fits all, and it's tailored and customized based on the subtype of breast cancer she has. So we customize and target treatment because different types of breast cancer respond to different therapies. And new therapies for each of these individual types are being delivered and developed all the time. For example, we have targeted therapy for what's called hormonally driven breast cancer. We have anti-hormonal agents. For HER2/neu positive breast cancer, another subtype, we have this drug called Herceptin. It's like a magic bullet. There are often times when women get HER2-related therapy up front, and then I perform the surgery, there's no tumor left. The medicine has actually melted it away. It's really, really quite extraordinary. The third category, which is called triple-negative breast cancer, one of the most aggressive types of breast cancer, for a long time, we struggled with how to treat that cancer because it didn't have any actionable targets. However, immunotherapy, using the patient's own immune system, and we have trials of this going on at Mount Sinai right now, has been an incredible step up in the treatment of triple-negative breast cancer. So I feel like on all fronts, we have something to offer everyone. And again, a backup plan for cases that are refractory and so forth. And it truly is not a one-size-fits-all. We customize not only based on the person, but based on the subtype of cancer that she has.
Excellent. That is really encouraging. So, Dr. Kopperman, tell us a little bit about how you're using precision medicine-based approaches in the infertility arena.
I think the perfect example is Dr. Port and I work together so closely. Dr. Port sees a patient, unfortunately, given this diagnosis of breast cancer, and she immediately says, all right, we may need to give you chemotherapy. They may interfere with your long-term ability to have a baby. So very quickly, I'm going to get you in today to see a fertility specialist. And she messages me. We get the patient in that day. And the first questions that I ask are triple negative, triple positive. It's no longer what is the organ that we're talking about. It's what are the genetics of the cancer. Is this a hereditary cancer that there's a gene that's responsible for? Because not only can we preserve this patient's eggs if she's a single woman, or take embryos and preserve, bank embryos if it is a couple. But if it turns out that it's a genetically caused cancer, and 10 to 15% have a known gene that have caused the cancer, we could take that embryo, screen BRCA or Lynch or one of these other hereditary cancer syndromes, and find embryos that don't have the gene. So you can take a family that has had aunts and uncles and grandparents and great-grandparents, breast, ovarian, prostate, melanoma, find the gene and make sure that generationally, that next generation is not going to express the cancer. So my friend here saves the patient's life, we preserve the fertility, and their family is then safe from the disease for generations to come. I mean, this is precision medicine at its very best.
Absolutely.
That's what we do at Mount Sinai.
That's fantastic. Woo! Love it, love it. So, Dr. Malaspina, you first mentioned precision medicine, especially around depression. Do you want to speak a little bit more to that?
Yeah, I also want to follow up on Alan's comment. You know, in my own family, we had an instance of a genetic variant, and actually did pre-implantation genetic testing, yielding healthy children. So we don't have too many of our complex diseases where we know that there is an informative gene. But as Alan said, those do not need to be passed on through the generations. We see this with Huntington's disease, for example, where individuals may not want to know in their reproductive years whether or not they harbor that gene, but they can have fertilized embryos, each screened, and have implanted the healthy embryos. And this is such a game changer for women who may want to have their offspring at later ages, who may have delayed childbearing for that reason. Do you know, for most cases with depression, already we can successfully treat the majority of individuals. We have medicines that are called SSRI. I don't like to use that interchangeably with antidepressant. That's because I trained before we had those medicines, and I saw how superior some others were. But someone who fails a trial of an antidepressant can move to another class of antidepressants. We know that certainly at Sinai, and psychiatric care aims to treat people with depression to full remission. This is very crucial. Someone with depression can be started on many meds and come back and say, oh, doc, I'm better. But better can't be good enough. We really need to treat to the resolution of that syndrome and back to resilience, which we can do. But for the persons and the proportion that have treatment refractory depression, we now have other medications like ketamine that can be useful, and we have brain stimulation. You know, ECT has been the most effective rapid treatment for depression. But now we have other forms of neurostimulation that are advancing. We're moving forward with direct stimulation, which may be much less burdensome to individuals or replace some needs for medication. And we're interested in depression as an inflammatory condition. Do you know there are some genes, of course, that are involved with the risk for depression? Each of them is very small. I think more of adversity, of early life trauma, prenatal, and even intergenerational trauma that can overwhelm evolved human systems for resilience. And in that way, really compromise the making of new brain cells, neurogenesis, and brain plasticity. All of our approved medicines, and even the experimental ones, are likely to be involved in brain plasticity. That means making new neurons, maintaining synaptic connectivity for processing. And all of our treatments are working that way. There's no badge of courage for tolerating a depressive syndrome.
Fantastic, fantastic. What you prompted me to remember, we use genetics quite a bit at Mount Sinai in terms of our treatment. We have a division of genetics and genomics in the Department of Medicine where we have experts in the field in genetic counseling. But one study I want to make you aware of is we're doing what we call the Mount Sinai Million, where we are recruiting 1 million of our own patients with who consent to have their genome sequenced, and the data are very well protected, put together with the electronic health record to really create an amazing repository to how to interrogate genetic origins of disease. And then the participants actually get some of their genetic data back if there's anything that's found in the analysis that's worrisome. And then of course we have mechanisms, as I just mentioned, to make sure that they're taken care of. This complements the All of Us study. If some of you have heard of this, that's a nationwide study to do much the same thing. So we're also bringing that to Mount Sinai, and I think between the two, we are going to have a very healthy, robust approach to really understanding genetic origins of disease. So very excited about that. So saying that, do you all use genetics in terms of determining who the best, or other clinical characteristics, to determine who the best responders are to certain medications? You'd mentioned HER2 and others,
Sure.
but are there other characteristics that you think about?
Absolutely, in our world. So as Alan started to mention, it's kind of a revolving door between our offices, but one of the key pieces of information that we get upfront in a newly diagnosed breast cancer patient, Monica, is genetic predisposition. So we all know there are 2 genes that were discovered in 94 and 95, BRCA1 and BRCA2. These are the most well-known breast and ovarian cancer predisposition genes, and as Alan mentioned, other cancers are associated: prostate, pancreatic, melanoma, male breast cancer. So the first thing we do when someone walks through our door with a new diagnosis of breast cancer is we do get them tested. And one of the biggest advancements in genetic testing as it relates to breast cancer is, in the last 20 years, since that time, other genes, predisposition genes, have been identified. These are known as these funny names like PALB2, CHEK2, ATM. We test for these genes because, number one, they can give us a better way to guide patient therapy, not only medical therapy. There are now these medications, they're called PARP inhibitors. And without going into the details of how they work and the mechanism, they're very, very effective in BRCA mutation carriers. And so when you test someone for the BRCA gene and you find out that they are BRCA positive, that may not only affect the surgery and the extent of surgery I do, it may open up avenues for medical treatment and drugs and drug therapy. So these are all incredibly informative results, and they affect therapy both medically and surgically.
Right, that's amazing. So not only do you can see what your risk may be through genetic
Yes.
testing, but it actually could influence your therapy.
Completely.
Absolutely. So, Dr. Kopperman, how about you? I know you talked a little bit about the genetics. How about other specific clinical characteristics that you look for? Or how do you decide on a course of therapy for a patient based on some of these?
Yeah, I want to add on to what Dr. Port said. Patients often come in and say, well, I have that 23andMe or other consumer genetics panel done. BRCA1 or BRCA2, they're tumor suppressor genes, but they're not just the 2 or 3 mutations that might have been tested for by their kit that they sent in a couple of years ago. There are thousands of mutations. So that now when you're talking about genetic testing, it's more, it's deeper, it's taking a better family history. And if I can get that information from Dr. Port about an estrogen receptor then I'm going to tailor the patient's treatment to keep her estrogen levels low, so I can use an aromatase inhibitor so her estrogens don't elevate, and I can get out the eggs that I need to help her achieve her goals without putting her at risk of having spread of the disease. So we're studying all the time this overlap between genotype, or the DNA, and phenotype, or what's expressed, and that's how you create these models to personalize medicine, how somebody's going to respond to medication in my world, or taking that deep family history. They've had a cardiomyopathy in the parent, they've had an autistic spectrum disorder child that has found to have a genetic link. There's a kidney disease that we work with the nephrologist. So you take this comprehensive history, you find the genes, and now you can actually inform them, empower these women, empower these couples with the modern technology, and they can make the decision. They're okay having a child that has a risk, or they can take that gene out, but we give them the information, and that's what this collaborative approach is really all about.
It's fantastic. Well, that's such a change from the day where everyone got Lupron, estrogen levels through the roof, and that's all there was. I mean, you've really come up with a really
we personalize it, we tailor it. What are their needs? What is their AMH level? What is the basal antral follicle count? What is their ethnicity? Not only what their self-reported is, but ancestral inheritance markers. How do people like them respond to different medications? The likelihood of implantation. What genetic test will give them the residual risk that they should know about of having an unhealthy child? All this is empowering the doctors and the patients.
Absolutely. Well, that's fantastic. So, Dr. Malaspina, any thoughts along these lines?
Well, I do want to add, you mentioned All of Us, which is a very, very important nationwide plan. It involves the recruitment and the life course ascertation of conditions as well as exposures and genes. The Mount Sinai Million is greatly oversampled for psychiatric disorders. So we will really be in the lead at understanding the genetic vulnerabilities for different psychiatric disorders and their relationship to outcomes. And I think that that's very important for the future of when we can tailor or even know in whom we must prevent the psychiatric illness. Also, because we have an exceptional electronic record, we can look for comorbidities. When you speak about a different cancer or an infertility, you might also look, as Alan said, is there a cardiovascular disease? Is there cardiomyopathy? Some of these are syndromes. The same gene that might cause a pulmonary dysfunction might also be producing pathology elsewhere. And with bioinformatics, we can tease those apart, relevant across these disorders.
Fantastic.
We just now actually used the BioMe, one of the Mount Sinai collaborative databases, and exactly that. We were looking for polycystic ovary patients in a certain gene in the AMH receptor, and we identified this cohort of men who were obese and hypertensive and high cholesterol, and we've just published on a new disease entity just by using genetics and screening. So we were looking for one thing, but unencumbered by a hypothesis, using machine learning, we were able to find a new gene that's related to a disease, and now we can identify patients at risk, and just like you're saying, recontact and say, time for your screening, time for your checkup. Don't wait to get sick. Let's prevent illness. That's the new paradigm in medicine.
Absolutely. And just to follow up, so BioMe is a repository that's already present at Mount Sinai that has over 60,000 patients, has a lot of clinical information, genetic information, and so that's already a wonderful database to really start looking into some of these genetic origins of disease. And of course, we have a real culture of innovation at Mount Sinai. Just yesterday, I was meeting with the machine learning AI group around building an algorithm, in this case for COPD, trying to understand who gets COPD, because not everyone who smokes necessarily develops it. It's actually about 20 or 30%. So who are those people at risk? So we can use the BioMe repository and our technology at Mount Sinai to really create these predictive algorithms. So I was very excited about that possibility. So that's just an example of the power that's available.
Sure.
But thinking about that, so there's a lot of information out there. So on the internet, patients are very savvy. They read, they get on the internet, they Google all kinds of things, and it can be very overwhelming, disturbing, and then depending on the websites you may look at, you may end up going down different sort of directions that aren't necessarily positive. So I'd like to ask the group, how do we help patients navigate that? Because we have so many amazing treatment options these days, but yet there's also a lot of misinformation out there. So I wanted to maybe reflect a little bit on that, and so get your thoughts on that, Dr. Port.
So this is a great question. I'm happy to answer it because one of the things that I noticed apropos of what I said in the beginning, that the treatment and the survival had never been better than before. Early in 2010, 2015, as the information age was exploding and the internet age was exploding, what I observed in my practice was that survival had never been better. We were quoting people survival rates of 90%, 98% in some subtypes of breast cancer. And yet people were coming into our offices with more doom and gloom than ever before. There was a total disconnect between the reality of the optimism we could offer and what they were sensing. And I made this connection. They were coming in with these printouts from online and these printouts from the internet with color-coded, highlighted 14 different colors. And I said, what's going on here? And what happens to women, so when someone is diagnosed with breast cancer, what does everyone say? Get information, get information. But the problem was not lack of information. The problem was too much information with no filter. And what ends up happening is that when you have breast cancer X, and as we talked about, there's so many different individual subtypes, and you go on the internet, you're going to read about breast cancer A through Z. And 99% of what you read, mostly related to doom and gloom, is not going to be relevant to your individual case. And so what I was noticing is that from the time that a patient got diagnosed till the time they got in to see a doctor like me to give them specific direction and to tell them what the treatment plan was and to raise their hopes and generate that optimism, people were going down these rabbit holes of misinformation. I did write a book about that. It is called The New Generation Breast Cancer Book, How to Navigate Your Diagnosis and Treatment and Remain Optimistic in the Age of Information Overload. And it was a direct response to what I was seeing. And the truth is, and this goes for a lot of different areas, is that the data and the facts are worthy of optimism. We are getting better. That is the truth, okay? It's the misinformation that's taking people to very dark places. And so that's why everything we do is data-driven, fact-driven, and I just hope that we can make more headway into really eliminating some of the misinformation that's out there, or at least insulating our patients from it a bit. I think that would be real progress.
I think so. What do you think,
Let's
Dr.
talk about where this comes from.
Yeah.
This anxiety is, of course, this loss of control. And how do we get control back? I don't mean to steal your thunder.
Oh, no.
But we get control back with information, with actionable insights.
Absolutely.
And so when that patient comes in with Dr. Google printouts, I tell my fellows, I teach this to our students, don't get angry with them, don't be resentful, validate them. They've gone down a rabbit hole. You have to help them get out of that rabbit hole. So you have to listen to them. They ask about a treatment that you don't think makes sense based on the evidence. Explain to them the reasons why. So if we poo-poo them, they're going to go to another doctor. They're going to go to all the doctors. The other thing that we tell our patients all the time is those journeys are not necessarily your journey. And that's piggybacking on what you're telling. They're going to read those. The patients that are the career patients that don't do well, they tell their story and they amplify that story. The internet is great for amplifying information and misinformation. Stories of joy can come out. Stories of sadness, they're very sexy. They come out often. And so helping patients figure out what information was helpful. Can I control my diet? Well, here's what the data say. Can I control my gut biome? Can I control my microenvironment? Well, you could stop smoking, you can eat well, you can take control of certain things, you can have low carbs if you have a polycystic ovary, but ultimately you're not responsible for this disease, and you don't have to be vigilant at all times about the disease. You can let us be the quarterbacks. That's why you come to us at Mount Sinai, because we're the ivory tower, because we use evidence-based medicine. We not only read the literature, we create the literature, but we have to listen to the patients, and it's not one treatment fits all.
Absolutely. No, that's fantastic.
Yeah, I
Lois.
think also we're dealing against stigma. So we have good news for breast cancer survival, great news for reproduction and successful overcoming of infertility, and for treating depression. But the stigma remains there. We are adding and delivering optimism to that story, and that really is a key piece of our message today. Absolutely.
Great. No, this is perfect. Thinking about what are some of the big areas of innovation? And I'm thinking about, certainly early detection.
Sure.
It's, of course, something that, many of us think about, we worry about as the years go by. So what are some innovations in that space that you might want to talk about?
Absolutely. I think, what we've gotten better at, Monica, is again, in the theme of customizing and tailoring, we all know that mammograms work. Mammograms are really the best way of detecting breast cancer in the general population. But they're not perfect. No screening test is. So mammograms pick up about 90% of breast cancers, and the best and newest technology, which is 3D mammography, is something we've been champions of for years since our centers opened at Mount Sinai. But there's a need to close the gap on those 10 to 15% of cancers that are missed on mammograms. And what we've done is gotten really, really much better at predicting who those people are and how to augment their screening with ultrasound, with MRI. We do genetic testing to pick out our patients at highest risk for breast cancer, where we then can personalize for them and say, you are at higher risk for breast cancer than the average person, and let's supplement to make sure that if, God forbid, you do develop breast cancer, we still have the best chance of picking it up early. So that's part of the the screening. And for breast cancer, screening is really quite effective and quite good.
How do we educate our primary care colleagues on all these wonderful things that you're talking about?
So I think one of the things is we need to do better at getting people in for mammograms. A lot of people, I call it, fell off the wagon with COVID. I'm seeing now patients who are diagnosed with breast cancer. It's 2023, whose last mammogram was in 2019 or 2018. And so fully utilizing and leveraging the amazing technology we have is so important. One of the biggest issues has been, in the last 6 months, there have been changes to mammogram recommendations. It's a very moving target. So we, who are the providers, know that mammograms, there's clear-cut data that mammograms save lives by picking up cancer earlier, starting at age 40 and yearly after that. And some of the other recommendations from USPSTF and American Cancer Society have muddied that water a little bit by distributing different recommendations. So one of the studies that I'm most proud of that we did at Mount Sinai about 5 years ago is, so everyone talks about how mammograms save lives. But one of the things that I turned around and noticed is not only do mammograms save lives, but we're saving lives doing less. And what we did is we did a study. This is the first, no one had ever described this before, ever. And we looked at all of our patients who came in with a diagnosis of breast cancer and put them in a couple of different categories. Those who had had a mammogram within the last 2 years, so they were pretty up to date on their screening. Those who had had a mammogram before, but much more distant. And those who, believe it or not, had never had a mammogram. Those people are, plenty of them walking around.
There are.
When you compare the regular screeners with the other two, the people who had had mammograms, way more likely to require smaller surgery only, lumpectomy instead of mastectomy, way less likely to need chemotherapy. Imagine being able to be treated for breast cancer and cured without chemotherapy, right? And the third thing is way less likely to need all their nodes removed because of spread of the cancer to nodes. It's a hugely devastating operation for women who need that because of cancer spread. They have risks of lymphedema, numbness. Who wouldn't want to avoid that? So we were the first group to show that by early detection, not only do you save lives, but you save lives doing less. And for me, that's a really important message that is highly, highly overlooked, and I never want to lose an opportunity to send that. So the technology we have works. We just have to get more people to get back on track.
I think your point's well taken. I think we also, I love the comments you made about our primary care colleagues, because really it's really they're partners with us, because we're all specialists. And so how do we get out there and educate? I know at Mount Sinai, in my world, I'm giving talks. Actually, Zoom has really helped that. I can reach a lot of primary care physicians around our health system, because it's such a large health system, and really talk about how to identify early detection, in my case, lung disease. Same for breast cancer. And I was going to say, Dr. Copperman, what do you think in terms of the primary care connection in your field?
It's education. It's disease prevention. We know that there's a fertility crisis in this country. We left replacement of 2.2 children back in the 80s. We're now at about 1.3 children per reproductive age woman. So we're not going to have enough people out there socially and economically to take care of us decades from right now. And part of the problem, or byproduct of the modern society, is women are waiting longer to get pregnant. And part of the biology behind that is that when you wait longer to get pregnant, it's harder. So when a woman is born, she's born with all the eggs she's ever going to have in her lifetime. In her 20s, 90% of the eggs are normal. In her 40s, 90% of the eggs are abnormal. So the great breakthrough that we've had is egg freezing, is fertility preservation. For men, as you pointed out, because the sperm actually will accumulate de novo mutations over time of a 70 or an 80-year-old guy, as we're reading in the news, can't procreate. But for a 35 to 40-year-old woman, if we can take out her eggs at 28 or 30, we can save healthy eggs for when she is ready to have a child, when she meets the right partner, when she decides to be a single mom by choice. We can thaw the eggs, fertilize her 28-year-old eggs, put a healthy embryo into her 40-year-old self to live her best life, have her family of a healthy child, and enjoy motherhood and parenthood in a way that she otherwise might not have. So we could prevent infertility with fertility preservation technologies, which have gone from media hype to medical reality.
And isn't there a lot of discussion going on around insurance carriers and getting involved in this particular aspect? Because it's really innovative, but it's very different.
Which is amazing, because you're seeing corporate America recognizing that recruiting and retaining female employees is really important. So what if there are fertility benefits that will allow them to access fertility preservation technologies, so they, not to enslave them, but to empower them to control their own reproductive future, to have reproductive autonomy. So a company like Google and Meta were innovators, but now law firms and a lot of tech firms are paying for egg freezing, 1 or 2 or even 3 egg freezing cycles, so that a woman is not worried that every single day her eggs are getting older, but knowing that she has safely preserved her opportunity to get pregnant on her terms when she's ready.
Wonderful, wonderful. Reproductive autonomy, I like that.
Yeah.
So Dr. Malaspina.
I also wanted to follow up on some of the aspects of prevention and primary care that cut across all chronic diseases. And that goes back to healthy food and to the gut microbiome. We've just completed a study looking at the gut-brain axis in depression and psychosis. And the findings for the gut microbiome are indeed impressive. We have many inflammatory forces that affect our health. And these accumulate as we age and may even be predictors of aging. But our anti-inflammatory potential is our gut microbiome. You know, does a primary care doc really spend enough time on 5 fruits and vegetables a day, minimizing processed food, healthy weight and diet? You know, an enlarged BMI is a big risk factor for inflammation as well. So we can come back to some final interventions that can protect women across their whole life course.
Give them things that they can control.
They can control, exactly. We know more and more about the impact of diet and a movement of nutrition as therapeutic. I'm absolutely sure we are moving toward that interface. We're all talking about what to do when a disorder is present or there's a limitation, and there is great, great hope there. But what do we do to start protecting the next generation? You know, for the youngest people, 18 to 24, rates of depression are skyrocketing. You know, we're looking toward understanding an impact of, for example, loneliness and sequestration. You know, feeling alone is a threat signal to the body and brain. So we're addressing loneliness. We're learning how to address healthy people and to maintain healthy people. And that cuts across all of our discussions today.
Right. I think the microbiome is fascinating because there's so much going on suggesting that in chronic disease, the microbiome is actually different. And there are interesting interventions going on to see if you can manipulate that microbiome to actually decrease the presentation of disease and modulate its course once it's there, once it's present. So I want to say, before we open it up to the audience for questions, I wanted to ask my amazing 3 panelists, are there some final summarizing words you'd like to provide for our audience today?
I mean, I would start by saying, you know, one of the things I always say about breast cancer is it is a devastating diagnosis, but it can also be, I've seen so many times, a very teachable moment where women do go on after breast cancer sometimes to live better lives than ever before. To Dolores's point, we have all of the framework at Mount Sinai, to deliver things like weight reduction, because being overweight and obese is a risk for breast cancer recurrence. So how could we not provide that framework for our patients to do better on that front? I've had patients come in a year after their breast cancer diagnosis, lost 100 pounds, off 5 medications that they were on for other things, and better than ever before. And you know, what I say is that you know, breast cancer is a disease, even though I'm the surgeon, breast cancer treatment is not tennis. It's not an individual sport. It's football, and it's a team sport. And while I know I don't look like the quarterback, I may be the quarterback, I am surrounded by an unbelievable team. And as we all know, a team is only as strong as the weakest link. So with people like Alan, who I have on speed dial, and people like Dolores, who can help our patients on, you know, the mental health front, we do try to leave people better than before, no matter what they come to us with.
Absolutely.
And I'm so proud of that.
Absolutely, a lot of optimism. So, Dr. Kopperman, any final words?
Yeah, let's keep spotlighting women's health. I mean, that's the key. And women's health for all populations, for all diverse populations that may not have that role model, that may not have that access to care. So let's promote states that mandate fertility treatment. Let's support genetic screening. Let's empower the internist with information so that when the patient goes to the primary care provider, takes a thorough history and says, I think that you should see a specialist because you may be at risk of a certain disease. Let's have more genetics counselors, because the future of medicine is genomic, and we're going to be able to treat mutations. We're going to be able to alter the course of a patient's future by targeting personally what it is that's afflicting them or they're at risk of.
Right.
Changing their microenvironment, changing their mood, empowering them with information. We can actually go from the single base pair that is a change or a variant in their sequence to the person that's going to have a healthier family and a healthier life.
Right, and just a couple words on diversity. I'm really glad you brought that up, because I think access is going to be key in all these amazing innovations we've talked about. And I'm really proud to say at Mount Sinai we take care of everybody. And so that's really important to our mission. And so I think we have to always have a DEI lens in everything that we do, just to be sure we have the access.
Million genomes. We have a diverse population. So this is not the hat map that was built on British middle-aged white people in the 1960s that we lean on for information. But this is today's population of people with varied backgrounds, and we could learn how to personalize their treatment based on their particular risk.
Exactly. Dr. Malaspina, any final words?
I want to highlight the amazing multidisciplinary approach at Mount Sinai and contrast that with some siloed academic medical centers where people do not have the necessary crosstalk to understand physiology and outcome. But my final message is that half of people with depression have no sadness. They may have body aches and insomnia, come to their doctor with GI problems. What they have is a loss of interest. Docs need to recognize syndromes of depression without sadness.
Really good point.
That would be what I want to leave you with.
Great point.
Very good point. Absolutely. So we'd love to open it up. There's lots of questions. We'll start with you. The lady right here. Thank you.
Perfect. Nobody talked about exercise, so how does that play into all of your fields?
Dr. Port, you want to start?
Right. I mean, I'm actually excited to hear about what Dr. Malaspina says about as it relates to depression and mindset and all those things. I will tell you, it's a very, very important part of breast cancer, I think, recovery and treatment. My big goal, I actually was just on the phone this morning with a woman who's a very well-known person in the exercise field in New York. I won't say more than that. And she's talking about what she will and will not be able to do during her treatment. And my message is always, you got to continue doing what you're doing. Listen to your body. If you're a marathon runner, maybe you're not going to run, 10 miles a day. Maybe you'll run 4. But exercise is critically important, particularly as it feeds back to weight. Can you be a very big exerciser and still be overweight? Sure. But of course, exercise and maintaining a healthy body weight usually go hand in hand. And we do know that weight control, and we were just listening to the head of the FDA talk about obesity and being overweight in this country is like the smoking of the 70s.
Absolutely.
And it is tied in. There's a huge range of healthy body weight and image, but there are objective measures of it leading to being unhealthy.
And can't we you can get a body scan actually here,
Yes,
right?
Yeah.
we can
We're actually
we can
doing that
body
at the Mount
scan you
Sinai
at the
tent.
Mount Sinai
That's right.
Pavilion.
Yeah.
I'm not sure I don't know if I want to do that or not. I'm kidding.
Yeah.
Information's good.
it's
Dolores, did you want to
important.
say
I just
something
want-
about that?
Yeah, we can talk about the antidepressants and I can talk about neuroplasticity, but there is a great natural driver of neuroplasticity, and that is exercise. You can put a rodent on a running wheel and double the size of its hippocampus. And I've sometimes seen people who are seeing a psychiatrist for the first time because of an ankle fracture and they couldn't run all the time. Certainly not all depression and anxiety is treatable by exercise, but a large part of it will be remediated. So thank you for bringing that
Great
up.
question. I was going to say, we'll start over here in the back. Right there. Yes. We'll go back and forth. And if we run out of time, we'll be available.
Yes.
The speakers will
Can
be
you hear
available
me?
outside to continue.
Thank you so much for your information about tailoring the treatments around fertility. I really applaud what Mount Sinai is doing. I am curious to understand a little bit more. A lot of these treatments are, you're sort of financially incentivized to promote things like egg freezing and IVF. And I think a lot of research into women's health is traditionally underfunded and somewhat dated. And I think IVF sometimes can circumvent a much needed understanding of the root causes of infertility. And I'm curious if Mount Sinai is looking into things like precision medicine, hormonal treatments, nutrition, things like that, that are maybe addressing the root of the cause rather than just the symptom. Because the average IVF cycle, if it's not covered by insurance, can be between $18,000 and $24,000. It's not, single women are not protected or covered rather, and same-sex couples are not covered. And so there's a lot of work, I think, to still be done in this space.
I mean, you're hitting all my talking points. First of all, piggybacking on that last question, health and wellness is important. We can't fat shame somebody. People metabolically, people culturally, people who are sad, sometimes it's difficult for them to lose weight. So health and wellness is great. Exercise is great. The range of BMI from really low or really high can create changes in outcome that are not always better. And IVF is the best diagnostic tool we have, because unexplained infertility used to be looking and doing surgery, and now we take an egg out and look at the egg. We take the sperm out, look at the sperm. We put the sperm into the egg. We look at the embryo. We genomically test the embryo. We look at it with image analysis over 5 days of development, and then we put it into a perfectly prepared endometrium. So not only will that work over 60% of the times, preventing 6 months of low-tech and unsuccessful treatment, but we're preventing twins and we're preventing triplets. The maternal fetal cost, society's cost of having high-risk preterm pregnancies is astronomical. So IVF is being found for people at genetic risk or people with unexplained infertility to be much more cost-effective, and it's time that insurers hear everything that you just now said. Let's promote the access to care for everybody, because that will achieve healthier outcomes for their medical surgical costs, for society, and healthier babies for mom.
Absolutely. Great. Question over here. Yeah, lady with the white hat.
Hi, I love what you're doing at your hospital, but I don't live in New York. There's a company called Nebula or something that does DNA testing. How can you get DNA testing from a reliable company? And once you get it, what do you do with it? And would you recommend testing a newborn, getting their DNA to predict what parents should be doing along?
Right. I can sort of start that, and then we can continue.
Okay.
There are a lot of sort of different businesses popping up that will do your genetic testing. It's tough. I think 23andMe is probably the most well-known, but they have their challenges also. And so I would be actually more prone to talk to do you have an academic center, medical center that's close to where you live? Oh, there you go. So I would probably head that direction first, because it's very likely many academic medical centers will have some type of genetic testing program. And then, of course, you can ask those questions around data privacy and getting some information back on actionable genes? Is there a study, like all of us, that you can participate in? I'm a participant. It's been really valuable because you can get actionable genes and pharmacogenomics. So that's really useful. I received some information I had no idea, and was really helpful for me. So I would tend to go that way. In terms of the screening for newborn, of course, I'm in favor, but I'm an adult doc, so I'm going to hand it over to my panelists if they want to comment on that.
So every state mandates a certain number of genes be tested for. For example, PKU, because you can actually alter the course of that child's future by changing the diet of an infant who has 2 copies of the PKU mutation. So advanced testing, such as testing a newborn to see if they have BRCA1, even if there's a strong family history, is frowned upon. You normally would want to wait until the child is 18 and can have the information and agency over their own future at a time when they can make decisions for themselves and be able to incorporate that information into their own health trajectory. So yes, very much in favor of genomics testing, very suspicious of consumer testing that is targeted. I mean, I saw recently an ad for, send us your cheek swab, we'll tell you what type of wine you like, and we'll sell you wine because there are certain SNPs that we found people that prefer salty or sweet flavors. And I mean, it's a cute idea. I didn't do it. I know what type of wine I like. But I think about a vulnerable population. Tell me information that is actionable, and I worry about the future of genomic testing, and I do worry about the privacy of this information,
Absolutely.
the actionability, and the accuracy of the information that's translated back to the patient.
Right. Well, I think with that, I'm afraid we've run out of time. I think there's another session happening. I want to thank my panelists. Thank you so much. Thank you all for coming.